So thyroid disease, I want to make a little sense out of this. And no big relevant factors here to disclose apart from my books. I want to make sense out of what disrupts thyroid function in perimenopause and menopausal women. And they are probably the largest group that has this affect their health. And it's such a huge thing. And it really affects so many. And in my judgment, there's a huge gap between what we know and what we do. And I would argue that that gap exists in the conventional world and it also exists in the alternative world. There's a long ways to go to really improve how we understand, how we diagnose, and how we treat thyroid disease. And I'll give you guys some tips to make a lot of that easier here. We'll make sense out of the main causes and also the first steps in those cases. The main things that disrupt that, is there a hand mic at all? Or not? It's okay. If there is, I'm hearing something mixed. Oh, I think there's a AV person to the rescue. I'll keep going in the meantime. Yeah, the main thing that causes thyroid dysfunction is autoimmune thyroid disease. I was talking to Dr. Kebeka here earlier. This is kind of distinct. I'll bring this point up real quickly. Thank you very much. This is a distinct thing in the natural hormone world. We're dealing with three main separate causes of endocrine dysfunction. And I think it's important to have some understanding of these being distinct causes because they really require different methods of treatment and different levels of understanding. The three distinct causes I think about are dysfunction and disease and aging. They're not all the same. You know, we see changes in adrenal function with age, and we see changes with gonadal function with age, and we often see changes with thyroid function with age, but they can be very different in terms of what gives rise to them. And if we make the mistake of treating them all as simple arbitrary lacks of hormone, we won't always achieve the highest outcome. So that's especially true for adrenal dysfunction. It's not Addison's disease. That's rare. It happens, but it's rare. It's more of a dysfunction of this entire system of regulation. So it's not just a lack of cortisol. But thyroid disease often is caused by a disease process. So it's very different in terms of the nuances and also many of the clinical implications based upon those three factors. The aging, you guys have heard quite a bit about good content on that today. You know, we're hardwired to have babies. We're genetically incentivized to have babies. But we're not incentivized to live for a long time. We would get in the way and eat up all the bananas. So that's the aging part of it. So the other thing that impacts this is ovarian function changes. You know, we think so much about the endocrine system, and we have these distinct glands with distinct jobs. But in reality, I think of it much more like a web or a net. There's so much interconnectedness. And what happens with one part of that web completely affects all the rest of it. So changes, is there a pointer on here too? Pointers are fun. Oh, I see, separate, okay. So changes, yay, changes in ovarian function are impacting changes in how the body's responding to thyroid hormones. So there's big relevance. We've also got nutritional abnormalities. And many of these are not unique to perimenopause or menopause, but they are often cumulative throughout the lifespan. And they're more apt to manifest when there is a lower amount of functional buffering available and lower amounts of tissue reserves. So things start to hit the fan once we passed our warranty period at age 45 or so. And then thyroid structural changes. Now, this is important to understand in its own right. The fastest increasing type of cancer in North America right now is thyroid cancer. There was a big paper that came out last week arguing that the rates of thyroid cancer now have more than tripled in the last 30 years. So it's a big thing on the rise. And this paper was good. They put some depth into distinguishing actual increases from earlier detection. And the consensus that it is actual increases. So this is very relevant. And I'll give you guys some tips about how that ties into this also. Okay, so autoimmune thyroid disease. You know that 8-to-1? I've seen some different numbers on that. I've seen some as low as 6-to-1, but most cases you'll see something around this range. And this is true for autoimmune thyroid disease, but autoimmune disease in general, very big factor in terms of female to male ratios. Some reasons for that: we know that there are persistent fetal cells that may be relevant, lower testosterone. I heard a good lecture by Dr. Lynn Patrick a few weeks ago arguing that some estrogen derivatives, some estrone derivatives may be large factors in autoimmune disease as well, and that female to male ratio difference. Many cases we can see X-linked immune abnormalities, that if all you've got is X chromosomes, they're more apt to manifest. But this is a very big bias, a very big difference. The prevalence of thyroid disease is quite high. If you make it to 80 years of age or more and you're female, you've got about a 25% chance of this showing up at some point in time by the more conservative estimates. And many have argued that it's probably even higher than that. So it is more prevalent. There's also strong data out now showing that along with thyroid cancer, thyroid autoimmunity is also increasing, as many autoimmune diseases are. And we'll talk a little bit more about why that's likely happening and how we can make a difference with it. Most common types of autoimmune thyroid disease, the biggest one here in terms of numbers is going to be Hashimoto's thyroiditis. Another good point I'd like to draw out quickly, Hashimoto's disease, within diseases we've also got different flavors. You know, we have pathophysiologic states, we've got histologic states, we've got clinical syndromes. So Hashimoto's disease, we'll talk more about this, it's a histologic diagnosis. And the relevance of that is that there are many clues that can make it suggestive of being present. There's a lot of rule-ins. What have we got for rule-outs for Hashimoto's? Any real strong rule-outs? Honestly, antibody tests are by no means rule-outs. They're over 40% false negative. So antibody tests in general, I think about them the way I think about psychics or astrologers. If they say things that make sense to my current beliefs, then I think they're worthwhile. If they don't, then it's all a bunch of bunk. So not a rule out. The only perfect rule out for a histologic diagnosis is a complete histologic evaluation, and that would be thyroidectomy with minced microscopic evaluation. Not a practical procedure in the clinical setting with the bulk of your patients. So no great rule outs. We have about a 10-to-1 difference between Hashimoto's and Graves'. Graves' is about 1/10 as prevalent. And these are not mutually exclusive categories. I'll show in some later slides that the differences between the diseases are one molecule apart. They're pretty close. And there's also a pretty fair amount of overlap. It's not at all uncommon to have both of these things together and have one be more predominant over the other.